This presentation is about the Symptom Assessment Scale, and my name is Sabina Clapham. So the Symptom Assessment Scale, or SAS, is a patient-rated measure of symptom distress, not symptom severity. The 7 items are the most common physical symptoms. However, symptoms may be added to this scale. The scale helps identify patient priorities relating to individual symptoms. This is the Symptom Assessment Scale form, but it's also available in a brochure format and a plastic ruler format that is available on our website. So it doesn't matter whether you record the scores for the patient or they do it themselves, as long as you've had a conversation and the score comes from the person who's experiencing distress. You can see we've added here words like bother or worry to help people interpret distress. The SAS is an 11-item numerical rating scale, with 0 being absent distress, not absent symptom, but absent distress from that symptom, and 10 being severe, the worst possible distress from that symptom. To help patients rate their distress, we've actually grouped the numerical scale into 6 intensity categories, and we've assigned a colour and a corresponding face. So the mild range of symptom distress is 1, 2, 3. Moderate is broken into 2, represented by yellow colour, 4 and 5, and 6 and 7, and severe 8 and 9 in one group and 10 on its own. The items included in the SAS: appetite problems, difficulty sleeping, breathing problems, nausea, bowel problems, pain, and fatigue. The 8th item is distress from other, and this can be added to the form, and you can add a number of different symptoms into the form if required. So patient rated is best practice. However, in palliative care, proxy assessment may be required. So you don't stop assessing symptom needs when the patient is unable to participate. So they may be unable to participate because of physical reasons or their clinical condition, or they may wish to not participate. So a proxy is someone who can answer the SAS items from the patient's perspective. SAS is part of a group of problem and symptom tools. So the other one is palliative care problem severity score. They work together to inform the palliative care phase and to develop a care plan for your patients. Key message: SAS describes the patient's level of distress. It's not severity, and it's relating to individual physical symptoms. To improve patient participation, you should always use a visual aid. If the patient is unable to participate, first ask a family member or carer. If the family member or carer is unable to participate, then you can complete a clinician-rated score using your observations and clinical judgment. So here's some qualitative data from questions asked to patients. Do you know why you've been asked to score your distress from certain symptoms? And here are some examples. I presume to check out how things are going, whether I'm stable or unstable, or to see how I'm progressing. I guess they want to see what progress I'm making. So some of these comments are the same, and of course you've got a few that say they're not sure. And that gives us areas to target improvement on how we communicate the tool, and particularly the concept of distress. Has being asked about your distress scores made you feel more involved in care? And this is overwhelmingly positive. So there's a lot of evidence that patients really do want to be asked. So, oh yes, notice has been taken of my reaction as to what is happening and to the care I receive. So you can see quite overwhelming responses here in this category. Do you find it easy to decide on the right SAS scores for you? And most people do find it easy. Some people ask for more explanations. And some saying, yes, I do find it hard on some days, particularly for some of the symptoms. And some symptoms I'm uncertain of. So again, that gives us areas to look to improve in how we communicate the score and when are the right times to ask patients to rate distress. This one is for staff, for clinicians involved in the assessment. Did the assessment tell you anything useful about the patient that you didn't already know, and if so, what was it? And so this is very interesting because often clinicians are saying that they're finding once you ask the patient, it opens up, ask people to talk about their symptom distress, it opens up a whole level of conversation. So this one here, the patient's assessment was higher than my assessment, and I learned that sleeping was a problem. And this one here, her distress about pain was going beyond the pain itself. I did not realise nausea was so significant for the patient. The patient's pain was more than I observed clinically. So again, it's giving an indication of the patient's the best person to tell you about their experience. This is an example from Peacock's assessment and response protocol, and what to do when you combine both symptom assessment scale and palliative care problem severity scores together. And for the severe range, which is 3 in PC-PSS and 8, 9, 10. And so in this case, the plan of care is ineffective and you actually need to do something immediately. It could be urgent interventions, referrals and escalation. You've got to change the care plan. You've got to review this patient within 24 hours. And this patient will be in the unstable palliative care phase, or if they're dying, they'll be in the terminal palliative care phase. So here you can find on our website a lanyard card with the definitions abbreviated and an abbreviation of the response, the assessment and response protocol. Thank you very much.